Antihypertensive drugs. Well, we're hitting there a massive chapter. 25 million of Americans are suffering from hypertension, and there are probably many more who are undiagnosed. Remember that hypertension is a silent disease, so you wouldn't know you're having hypertension, yet no organ is spared. What's the vascular problem associated with hypertension? Are you saying hyaline arteriolosclerosis? Increased risk of atherosclerosis for the large vessel? If you think at least of these two vascular pathologies, I'm happy, because now you understand what's going to happen. The potential for ischemia of organs, of tissues, and the high risk of developing hypoxic damage, potentially irreversible hypoxic damage at this, with infarction down the road. So as I'm looking at antihypertensive drugs, I'm probably looking at one of the major group of drugs to know in and out for any board exam, and also just simply for practice. The actual strategy is so much easier than looking at antiarrhythmic. We all remember Fick's law applied in physiology to a mean blood pressure, whereby mean blood pressure is literally controlled by two major parameters: cardiac output, heart rate times stroke volume in essence, and total peripheral resistance. Don't forget that resistance is directly proportional to viscosity, length, but also the fourth power of the radius. Logically, then, if I want a parameter that really changes blood pressure dramatically, I need to work on total peripheral resistance. I want a drug that could interfere with that radius. Any change in the radius of a vessel being magnified to the fourth power is bound to dramatically alter the blood pressure. So overall, two big strategies for my drug when it comes to hemodynamic. Having a drug that either decreases the total peripheral resistance and decreases the cardiac output, that is the heart rate or the stroke volume, in order to lower the patient's blood pressure. The other approach, a little bit more drastic and using the renin-angiotensin-aldosterone system, would be to literally dehydrate the patient, decrease the body fluid volume. As you do this, you would work primarily then on the preload more than the afterload, and as such still diminish the amount of return flow to the heart and thereby decrease the cardiac output. Well, we'll talk of decreasing body fluid volume with the diuretics, and this will be a section in its own, since there are so many things to discuss about the diuretics, their uses and their side effects. One issue we'll encounter with drugs that lower blood pressure is what we talked about in the autonomic nervous system, which is as we drop blood pressure, particularly if it's fairly sudden and if the intensity or the magnitude of change is big enough, would be the potential to result in reflex tachycardias. Reflex tachycardias have in mind to try and undo the antihypertensive effect of a drug, but also can potentially increase that risk of angina and possibly even myocardial infarction in that patient. Reflex tachycardia will increase oxygen demand in the heart. So often we'll have to add on drugs simply to remove the reflex tachycardia as we lower that patient's blood pressure. The other big homeostatic regulation is the renin-angiotensin-aldosterone system. As blood pressure drops and as we know perfusion pressure in the capillaries of glomeruli decrease, then we know we're going to see an increased production of renin by juxtaglomerular cells. Then angiotensin II will constrict, aldosterone will result in increased fluid retention. It is that salt and water retention from aldosterone that is associated with a classic edema of antihypertensive medication. This is why not only I will have to treat reflex tachycardias, but also the side effect of edema of most drugs that lower blood pressure. Well, with this as an introduction, we can really split our drugs used for blood pressure management in two groups. First, the group that comprise the autonomic nervous system drugs, and then the drugs that are called direct-acting dilators, which have nothing to do with the autonomic nervous system. Look, let's take ourselves a little page, if you want, and let's put ourselves a few notes before we get started looking at the drugs. If you're a drug that lowers blood pressure through decrease sympathetic autonomic nervous system, Well, as you decrease the sympathetic autonomic nervous system, maybe one of the first things you should think of is that you will not see reflex tachycardia. You should not see reflex tachycardia because that reflex increase in heart rate was due to the sympathetic activity releasing norepinephrine and stimulating beta-1 receptors. So reflex tachycardias are very unlikely with drugs that work directly on the autonomic nervous system. Well, if on the other hand, on the other side of the page, we show the drugs that lower blood pressure without having any sympathetic effect, without sympathetic ANS decrease, then we would expect reflex increase in heart rate to become an issue. So here's a big difference right there already. We should see bradycardia with antihypertensive that breaks sympathetic activity. Let's do another one. Every time you stand up, a physiologist will remind us that we need sympathetic activity to release norepi, bind to alpha-1 receptors of our vein, venoconstrict, and help the blood return to the right side of the heart. If you're interfering with sympathetic, you are very likely to have orthostatic hypotension as a side effect. Orthostatic hypotension is certainly not the best thing to have on the planet. Again, if we think in terms of angina, potential for MI, to be downstream from having hypertension. There's really no issue with orthostasis causing hypotension with the direct-acting drug. I mean, these are just generalities, and believe me, we'll find some exceptional drugs in either group, but just as generalities, they're neat in order to try and separate the two groups of drugs. Let's look at another story together. If I lower sympathetic activity, I should expect all these drugs to result in too much parasympathetic activity in this patient. With too much parasympathetic activity, you know what it means. Increased secretions. You know that's not good for COPDs. That's not good for ulcer type of patient. Surely, I would also imagine that with increased parasympathetic, I'm going to get some GU problem. You would expect diarrhea, maybe incontinence to settle in. So all these stories would be absolutely irrelevant of a drug that doesn't work on sympathetic. There would be no increase PANS with the drugs that have nothing to do with autonomic innervation. So make sure you have in your mind that dichotomy in pharmacology right now of the antihypertensive that works through decreasing, altering sympathetic activity versus the ones that won't.